Thank you for having me here today. Perhaps I'll start by telling you a little bit about the Victorian Managed Insurance Authority, or VMIA as we're more commonly known, and the role that we play for the state. The VMIA is the state government insurer. We're a captive insurer. We insure all state government assets and employees, including the entire Victorian public health system and health network. VMIA has a dual strategic role of providing both risk management advice and insurance to government departments and authorities. We receive and manage all claims and proceedings issued against Victorian public hospitals. We're the largest medical indemnity insurer in Australia, and our medical indemnity portfolio is our largest insurance portfolio. VMIA also has a dedicated insights team whose role it is to draw data from our claims portfolio to identify current and emerging claims themes. And this means that we're really in a unique position to monitor the impact of legislative change, healthcare policy, sector trends, and identify trends and causative themes arising out of our claims portfolio. And we use this information to drive health sector risk initiatives through our medical indemnity risk team. By way of snapshot, in Victoria there's 304 public hospitals, public community health agencies and state medical research organisations. Last year there were 1.59 million hospital admissions, and our health sector is subject to an annual population growth of 2.1%. We receive about 250 claims per year in the medical indemnity space, and our medical indemnity portfolio represents 60% of our premium allocation and about 67% of our claims cost liabilities overall. So it's by far our largest and most expensive portfolio. In terms of surgery, this slide shows the trending numbers of surgical claims over the last 7 years. The blue line represents the actual numbers of surgical claims per month, and the green is a 12-month rolling average. The rolling average for surgical claims currently sits about 10 claims per month. And whilst there's been distinct peaks and troughs, you can see on that graph throughout the illustrated period, the rolling average shows a pretty gradual but consistent trend upwards. We believe this is indicative of an increasingly higher volume of patients being treated by surgical specialties. Claims in this area also appear to be influenced by an increased complexity of patients presenting for treatment due to a range of factors, including acute levels of illness, high numbers of comorbidities, making their treatment more complex in an ageing population. Comparatively, we receive more surgical claims than any other specialty. So in terms of what this means for claims cost to the state, surgical claims represent the third largest cohort of claims payments made by VMIA. Of the surgical specialties, orthopaedic claims are our greatest cost. Not surprisingly, you can see there that maternity continues to be our greatest exposure, and whilst these claims are fewer, they're obviously high quantum because they're associated with lifetime care costs in relation to a child born with cerebral palsy. Emergency medicine follows very closely behind maternity, and in fact I think last year was almost level with maternity in terms of claims costs. The number of emergency department claims, coupled with an increase in poor outcomes, has led to a greater expense in this area over the last 5 years. Now I'm going to talk to you about a taxonomy project that we're very excited about at VMIA. VMIA purchased a taxonomy program from a MDO in September 2016, and our insights team customised the methodology to capture causative factors in our VMIA claims portfolio. And the purpose of this is to inform actuarial assumptions, but also to drive risk initiatives to address systemic issues in the public health sector. We backcoded 6 years of claims data, which was more than 2,000 claims files, and we're on coding as claims come in. The purpose of this is twofold. It looks at what happened, that is the presenting disease, comorbidity, symptoms, diagnosis and treatment, and why adverse outcomes have occurred on particular files, so causative and contributing factors. So the slide that's up there at the moment illustrates that errors relating to management and treatment of patients, diagnosis and procedural error in surgery are the most significant drivers we see in our claims files. For clarity, examples of critical causes would be misidentification of anatomical structures, for example, during the intraoperative period, and examples of contributing factors might be a failure to diagnose a complication such as a perforation. So moving on, we're also able to draw data showing where the high-frequency critical causes sit across our top 5 most frequently represented specialties. You can see on that slide that 41.7% of orthopaedic claims and 55% of general surgery claims relate to procedural and surgical error, followed by management and treatment errors at 41.7% and 21% respectively. Our taxonomy enables us to drill down even further, and this slide illustrates that diagnostic errors are most commonplace during the initial assessment and relate to failure to consider differential diagnoses. Poor surgical performance relates primarily to the skill and competence of the practitioner intraoperatively, and management and treatment errors centre around pre- and post-operative assessment and management leading to poor treatment plans. Now, this I find particularly interesting. This is comparative data from overseas. So, CRICO is the Harvard Medical Institution insurer in the US, and data drawn in June 2018 from CRICO's comparative benchmarking system across all US states shows that while the rate of surgical claims has been declining over the last 5 years, they still remain the most prevalent and most costly cohort of claims in the US, followed by general medicine. In the US, surgical claims outweigh maternity and ED, unlike here, but there are key similarities in that orthopaedics is the most prevalent and expensive specialty. Cases relating to improper performance of surgery, poor technique and improper management of surgical patients are the most critical, significant factors, and communication with other clinicians and the patient or family, linking in with consent issues, were also identified as key issues in their claims portfolio. Turning to the UK, NHS resolution identifies and indemnifies and handles negligence claims on behalf of the NHS trusts, public trusts. Like Victoria, surgery again is significantly overrepresented in claims per specialty and is the second most expensive claim specialty after obstetrics in the UK. Now I want to move on to share some insights in relation to what we've identified as key and current emerging risks for surgical specialties. To fulfil our role as a key risk advisor to the state, we recently engaged external consultants to help us identify these risks by conducting stakeholder interviews and environmental scans both here and overseas. They grouped the areas broadly into those 4 categories, that is those risks that already exist but may increase, those that may be driven by new legislation, those likely to be driven by an increase in public awareness, and those that appear to be relatively new on the horizon. I don't have time today to cover them all, but I have extrapolated those that are most likely to relate to surgery. In the areas that currently exist, a key risk was identified was the management of overweight obese patients. Obese patients obviously affect a large proportion of the Australian adult population, and it's associated with a higher prevalence of chronic health conditions. In addition, overweight or obese patients have been shown to experience a higher rate of complications during hospital care. They've got a higher rate of admission to intensive care, longer length of stay, predominantly higher likelihood of experiencing an unplanned readmission to hospital within 28 days. So some of the specific risks that were identified in relation to medical indemnity claims throughout our own portfolio were a greater risk of infection, thromboembolism, airway maintenance, difficulties in positioning for surgery, IV access, surgical site access and pressure injuries, and the need for specialised equipment which may not be available in a rural setting. Given the rise of obesity generally across the Australian population, it's expected that the number of patients with this as a comorbidity and a complicating factor will rise, and of course that flows on into claims experience. Hospital-acquired complications as a result of suboptimal identified as more likely to occur with surgical admissions and is causative around 15% of adverse events that occur in hospitals generally. These hospital-acquired conditions are now more explicit in Australia, and they're published in the Hospital-Acquired Complications by the Australian Commission for Quality and Safety in Healthcare. And I understand also from the 1st of July 2018, the prevalence of these conditions rolls into a reduction in funding across hospitals. Whilst there are obviously key initiatives for patient safety, we do expect that this is publicly available information can be used as evidence of negligent care. It's quite sobering to note, actually, that healthcare-acquired complications in the US cost their health system $9.8 billion a year. And whilst clearly we're not the US, it does demonstrate the gravity of the issue, which has the potential to flow on to claims here in Australia as well. Of stakeholders interviewed, they also raised that there was a lot of potential for medical indemnity claims relating to the provision of perceived unnecessary procedures or treatments. These were procedures that either lacked an evidence base in terms of improved outcomes or were equally effective and less invasive treatment options existed. Where implementation of these procedures results in adverse outcomes, I think we can expect the greater incidence of claims by individuals. And if I just move on to the next slide, an example of public airplay around this is this article at The Conversation, which refers to a Grattan Institute report highlighting indicia which might suggest that surgical treatment options offered by doctors were inappropriate. So I think, access to social media and further conversation around this may well lead to an increase in claims in this area. Finally, in relation to current risks, anecdotally, it's not uncommon in our claims profile to see workplace culture influence patient management and care adversely. In particular, instances where junior staff feel intimidated about escalating cases to more senior colleagues in a timely or appropriate manner, where concerns of patients or families in relation to their condition aren't acknowledged, and poor communication in relation to procedures, risk, expected outcomes and follow-up care, and we see that a lot in our claims portfolio. Turning to areas influenced by new legislation, in November 2017, you'll all be aware that the right of individuals to end their own lives under specific conditions was legalised in Victoria. Likewise, in March 2018, legislation enshrining advanced care directives came into effect. While a great deal of work through has been done by many hospitals and Safer Care Victoria in this area and is underway currently, testing of alleged non-compliance with these laws and subsequent medical indemnity claims related to wrongful death are possible. Turning to areas influenced by public awareness, a key area of litigation influence associated with public awareness rests in the class action space. That quote there actually comes from one of the plaintiff lawyers' websites, and there's a great deal of advertising around class actions generally. In particular, we've seen recent class actions around transvaginal mesh and hip implants, and whilst these class actions are generally taken against the manufacturer, credentialing and experience to use the devices invariably plays out in a litigation space, and it was in fact recognised as a contributing factor to implant failure in the Senate inquiry into transvaginal mesh. Generally, the increasing litigiousness of the public, fuelled by media coverage and advertising by plaintiff firms, provides greater awareness about the possibility of suing for damages. Then finally, turning to what was identified as being on the horizon as a litigation risk in the surgical area, consultants have pinpointed local 3D printing of medical devices as a potential example where technology may move ahead of clinical governance. Whilst new technology and ethics committees exist to oversee the implementation of these processes, close monitoring will obviously need to take place to ensure that hospitals that engage in 3D printing of medical devices are aware of the risks associated with that as manufacturers of these devices. And finally, another key issue was the transition of hard copy records to EMRs. So we know that a number of our hospitals are transitioning to EMRs at the moment, and there's obviously a danger that a complete clinical picture may be lost. You've got hybrid medical records with the migration of information, and some difficulties will obviously arise for practitioners in terms of accessing and using the EMRs themselves. So that's another key risk identified that hospitals need to turn their mind to when rolling out EMRs. Now, I'd just like to close my session today by showing you one of the risk initiatives that VMIA does in relation to patient communication, which is a key risk area identified in our claims and by our consultant. This is the In Their Shoes campaign. It was developed with the assistance of Monash Health and Safer Care Victoria, and it is aimed at improving communications between doctors and patients in the clinical setting. So if I can get this to work, I will. Here we go. Is there a volume? Oh, here we go. It's just music anyway, I think. Not quite as powerful without the music, but hopefully, or as powerful as the Cleveland health video that you've probably all seen yourselves. But anyway, I hope you understand the message, and I'm happy to take any questions that you might have.